Everybody, my deepest apologies, my deepest thanks for inviting. Sound okay?
Now we can't see you, but I'm sure they will sort it out.
Okay, they will sort it out. As long as you see the slides. Slides okay?
Nothing is okay for the time being except for your voice.
I'll start with slowly. Tell me what
Now it's fine.
I start. It's okay?
Yeah, now it's fine. Thank you.
Okay, so thanks for the invitation. Thanks for the kind introduction, and I will take 10 minutes to tell you everything that I have in mind about alternative slides. My deepest sorry for not being there, so I'm very, very close. So let's talk about what we can do when we don't have femorals. That thing, we don't have femorals, was not an issue back 20 years now, because we tried to save unsalvageable patients. But the comment I want to make here is that with a self-expanding valve from day one, the transfemoral route operated by us, the cardiologists, and closed down by us, the cardiologists, was the default options. Other technologies needed some 5 to 10 year time to catch up, because at that time they were dealing with surgical cut down. So the surgical option was in hand, on the table from day one. Now, meaning now 5 years ago, TAVI is an everyday case in many, many experienced labs. I'm not showing you to show that the gradient went down. I'm just showing you to see the times, like in 20 minutes, skin to skin, the gradient goes from 50 to 0. And that's something that's very, very fascinating. And we've written that down. It's the same time around 2019, the people that at that time were dealing with TAVI. Data from the States, from the STS registry, that started to show what happens in the real world, say that nowadays almost 95% of cases are being done transfemoral, and only 5% of the TAVI cases are being performed by alternate sites. The guidelines that came later on, about 2021, say that you have two TAVIs. You have the transfemoral TAVI, which is the TAVI that we all talk about, and you have alternative sites, alternative access option TAVI. When you mean alternative, you have to make a much more serious and deep consideration about the alternative option that is surgery, because transfemoral TAVI does not equal to non-transfemoral TAVI. And we have data to show that all the good data being TAVI equal, non-inferior, then equal, than in across all risk profiles, from very seriously diseased patients to low risk patients, are dealing with transfemoral TAVI. When you go non-transfemoral, the numbers for us interventional cardiologists are not that good, and that's from the initial partner and from the partner trial. And you have alternative access, you lose your so-called advantage over the surgical colleagues, and I can see a lot. And that, again, from the STS registry, you see from a medium 3% mortality in transfemoral against thousands and thousands of patients. When you go to alternate sites for access, you have to accept, you have to talk to your patient that the accepted mortality rate goes up. So I close this introduction by once again stating that transfemoral TAVI is not the same as not transfemoral TAVI. So why do we have to deal with non-transfemoral TAVI? Why don't we just put everybody in? Because big seats are big seats. Initially we were 22, then they went to 18, then we get down to 14, and I think that's going to be the end of it. And when you have a very tortuous vessel, or you have a very stenotic vessel, you just cannot push your stuff across that vessel. You cannot push that 5mm sheath or system across that stenosed or tortuous vessel. And that's from the editorial from Winteker last summer, that says you have a spectrum of a whole gray zone, from a perfect candidate on the left to a little bit calcified or tortuous to a lot of calcified, or you have complete peripheral artery disease with occlusion, or you have a TEVR, although we put through a few TEVRs inside me and Kostas Toutsos. But then you have serious unfavorable anatomies, which for just plain anatomical reasons, you cannot push stuff across. But if you just have some stenosis, you can deal with that in order to proceed with transfemoral TAVI by doing a peripheral angioplasty. And that's a common practice. We've started with easy lesions, and now they have the whole thing about paving the way all the way up with crushing balloons and with shocking bolus, and all that stuff. So you have a way to avoid non-transfemoral TAVI. When you cannot avoid transfemoral TAVI, and that's a consensus, a C, a level of evidence C, that's expert people like you said, when they are inoperable and you cannot do transfemoral TAVI, then the non-transfemoral TAVI is the third option and not the second option. And regarding access, also from the same STS registry, you see you can have transapical and you can have subclavian, which is number one in numbers, and then you can have direct aortic, and then you have so-called, in my mind, exotic options like carotid or subclavian. The thing is, with all these options, you need anesthesia. Take along, some centers perform transsubclavian access through local anesthesia, and that is an option, but it is far from widely being accepted. Okay, you need anesthesia, and we've said that, and people say that there is no problem if you have TAVI with or without anesthesia, but again, I'm sure that our fellow anesthesiologists would not, drop their hat on the air about giving anesthesia to the upper right-hand side lady, because you have the problems of anesthesia, we have the problems of feeding, and we have all those complications that come of having a tube in your mouth for 1 hour. So what are the alternative options? Subclavian options. So you do a small incision, you need the second team, you need a set-up room for operation. So you need the second team, you need the third team of anesthesiologists. You operate either directly and you puncture directly the subclavian artery, the left or the right subclavian, or you put a side-by-side graft so you be easier to puncture the graft, and then you cross the valve. That does not come always without complications. And also you have a complication. Here you can see there was a dissection of the subclavian artery after a TAVI, which dissection led to the occlusion of the functioning left IMA, and then we had at the end of the procedure to perform transcorval left main PCI, because we occluded with our operation the left subclavian artery and the lima. But also again, we have not another option. Here you see you can also, it was the only option at that time meaning 10 years ago, and that was the first case we sent in the first ever PCR London valves. We had to do transsubclavian in the same way that we do in the peripheral arteries angioplasty. We can do transapical. It was very widely in balloon expandable valve used, especially in the initial seats that needed to be 20 or 22 French. The surgeon with a small hole at the beating heart performs a puncture and then closes the puncture, and it is an easy option not only for the aortic valve and also for mitral valves. You have the direct aortic with a small incision. You puncture the ascending aorta more than 6 centimeters above the aortic annulus, and we were proud we were the first to describe and to present, to perform that. And it could have some theoretical proven benefits against the transapical, but it is not either the transapical or the transaortic. It is surely inferior to the extra cage to the subclavian surgery. So if you can avoid surgery, avoid it. And if you can have extra thoracic cage surgery, it's better than having intrathoracic cage surgery. What this method led to was to the manufacture by companies of sutureless surgical valves that more or less were based on the same way. There are the exotic options. You can puncture the carotid artery and be close to the heart. You can puncture through the inferior vena cava the descending, the thorax, the abdominal aorta, and then close it by means of closing a PFO on your way out. They have good results. I have not done it. I'm sure that in these cases, the surgical would not be a bad option. And cleaning and closing, I would say that the more you add surgery, the more you add problems to your patient, and the more you have to think and to discuss with the patient the alternative option. In the 95% of cases above 70 years old that you can do transfemoral TAVI, you should proceed. If you can do something to make the transfemoral option possible, you should do that. Otherwise, you have to do another discussion. It's not TAVI versus surgery, it's TAVI versus surgical TAVI versus surgery. And that's what the guidelines say. If you can do transfemoral TAVI, proceed. If it's impossible, you'd better do surgery than doing a sort of hybrid surgery TAVI. Otherwise, I've done a 96-year-old, if the surgery is always out of the option, then you can try to do alternate option. Thank you for your attention. Sorry again for not being here. I'm happy to discuss any questions you might have.
All your experience to us and to our audience, and I would like now to ask Dr. Mavrogianni if she wants to make any comment or have any questions, and then ask the audience.
No, I have no comments to make. I think, of course, your first choice is always the transfemoral access. If you don't have the transfemoral access option, then subclavian is rather good, but it's tricky and it's technically challenging if you don't have enough numbers. How many patients did you go to via subclavian, George? How many patients did you treat via subclavian route?
Overall, as a percentage.
I didn't hear you. Clear?
Overall, or as a percentage. As a percentage, it's about 1 out of 30. Nowadays, that the seat with some hospitals go down to 14, there are even less.
Okay, perfect. This is your second choice. You always
Yes,
you should always go transfemoral. This is the second and third option when your transfemoral is very hostile. I have no comments to make.
Dr. Bellakis wants to have a comment. Please do, Dr. Bellakis. I know that you're a bit difficult not being around, but now we've seen you. Okay, please do.
Morning to everyone. Thank you for the invitation on this fantastic meeting. I'm not there. I'm just probably 1 kilometer or 2 kilometers away, but it's unfortunate I cannot be with physical presence. Congratulations to Dr. Latsios for his excellent presentation. I just would like to make a comment. Sometimes we consider the sutureless aortic valves to be an alternative to TAVI, which is not exactly true, because still these valves do need to put the patient on bypass and still do need some sort of incision. So more or less, these valves are made to make the surgical time less and maybe treat some more hostile aorta. So still, it's not a good, let's say, it's not something comparable to TAVI. Now, my second question is, I just try to think what happens to these patients that one of these cases was described by George, who have patent lemmas. These patients are basically, no surgeon wants to operate and do a redo operation on somebody who has a patent lemma. We prefer these patients going for TAVI if they develop aortic stenosis after bypass surgery. And I know that the subclavian access on the left side is the preferable one when we're doing transsubclavian TAVI, but then we have to deal with the lemma, and occlusion or dissection might cause unfavorable outcomes, and it was a good save what George did. But I was wondering whether these patients should be considered for a different access route straight on. I mean, when we see a patent lemma and we have no access, a transfemoral access, whether we should go transaortic or transapical or a different access. Thank you.
Okay, thank you, Dr. Beralakis. Thank you, Apostolis. First of all, the case with the occluded lemma was something that happened back in 2008. So nowadays, when we have the bad option of a patient that's been, let's say, 85, that's got a patent lemma, and that's got a severe stenosis, and that's got no peripheral access, then we have a big problem, and we have to deeply discuss all the options. So we cannot go transfemoral, we are not willing to go trans-left subclavian. We have to see what the other options are. Per se, the patent lemma is not a contraindication to transsubclavian TAVI. If you have a big subclavian, then you're not afraid that you will occlude the lemma. If you can avoid it, it should be avoided if you have an alternative option. But again, let me say that the cases nowadays, with the help of the companies that are shrinking the sheets, the cases that you cannot go, the companies shrink the sheets, and the experience of the operators of going transfemorally through TEVARs, through angioplasties, through peripheral angioplasties increases. So the cases that would need to go surgically much decrease.
The last one by Dr. Batakos, because we have to.
Yeah, just so in the sake of time, fantastic. Thank you, Dr. Latsios, for being with us. It was a fantastic talk. You know, I always think about a little bit these alternative access routes. Part of the issue is I think clearly we all know transfemoral has the best results, part of it is a selection bias, I think, because the patients who are not candidates for transfemoral are the ones who have a lot more comorbidities, a lot more peripheral vascular disease, a lot more health problems in general. And so then it's obvious that they won't have as good outcomes because they're a sicker population overall. We have jumped late on the bandwagon for doing a transcarotid TAVR, but I think it's a very good option, especially in cases like Dr. Roubalakis and yourself are talking about patients who have a patent Lima LAD. You don't want to go subclavian. I think the transcarotid route, as scary as it sounds initially, we've had a good, limited early initial experience, no strokes. And so I think that there are always other options to discuss. One of the first cases I saw when I was a young cardiothoracic surgery fellow in Houston was a trans left subclavian TAVR in a patient with a patent Lima LAD, and the patient died on table. The vessel was dissected, the flow in the Lima stopped, and the patient coded on table and died. So it's a very traumatic experience. So I would say that that's something that should definitely be avoided, especially when in this day and age of exotic things like transcaval, there's always, in transapical, there's always another option. But thank you for your excellent talk, and I'd love to hear your thoughts.
Thank you very much, Dr. Patakos. Thank you very much, George. And we have to proceed with our next speaker, who is